Y'all, welcome to the South Carolina Fall Forum. I am so excited we are all here today. Thank you for coming. I want to welcome our core members who've been working very hard over the past 6 months. It's great to be in the same room with you guys. I missed a couple of the July meetings because I was out of town, but I'm just thrilled that all three cores are in the same room. Very, very excited. I want to welcome our North Carolina neighbors. We're really happy that you guys are here and you're going to share your passion and enthusiasm with us for what you do. And I'd like to welcome our special invited guests. We hope that you hear something today that inspires you, that moves you, and that you'll want to learn more about the discussions that our cores are having that are really focused on building a shared infrastructure around social determinants of health in South Carolina. Before I give y'all a quick history about how we got to today, there are many thanks I need to make. First, it is to my project team and my admin team. So Ashley Moncrief, Janisha Nance, and Holly Pope, and then out in the hallway we have Katrina Plyler and Shannon Porto. Y'all have worked their tails off to get ready for today, and they've been working really hard over the past several months. They are flexible because that is what this is all about, is being flexible and pivoting and, changing directions multiple times. And I couldn't do it without them. They are my dream team. So I want to thank them. I'd also like to thank the co-chairs. So I was able to finagle and coax and lure in 6 amazing, powerful women, Renee Leonard-Gary and Carrie Rothschild, to serve as our programmatic core co-chairs, Melissa Fair and Summer Thibault for our data core, and Vicki Young and Naomi Lett for our admin core. Y'all have done everything that I've asked of them. I've asked them to be candid and direct with me because I am not good at reading in between the lines. They are wonderful about serving as our support system and our sounding board to really help us guide us through this work. So thank you to my co-chairs. Y'all are wonderful. And I really do want to take a minute to thank our North Carolina neighbors for driving down here and joining us today. I have a funny story I want to share with you. When I sent out the invitations, I was like, oh my goodness, it's getting so close to the September date. They're not going to be able to come. Oh my gosh, I was getting stressed. And honestly, at that point, I was like, okay, if it's virtual, it's all virtual. It's going to be good. They all said yes to come into town. And then last night, we all went out to dinner, and still just overwhelmed and thrilled that they were here. And then I learned that many of them have never been in the same room with one another. They have been doing their work virtually. So they had to come to South Carolina to hug one another on our dime. I was like, this is perfect. So thank y'all. And I want to do a special shout out to LaQuana Palmer with the Foundation for Health Leadership and Innovation. She really helped me figure out, I'm like, this is what people want to know. Who are the people we should have from North Carolina? So thank you so much, LaQuana. We're so thrilled y'all are here. So. And last but not least, I really want to say thank you to Erica Kirby with the Blue Cross Blue Shield of South Carolina Foundation and Chris Collins with the Duke Endowment. And I'm not thanking them just because they invested in this work, but also because they really have made a push. With their leadership, I think these conversations may not be where they could have been without them investing not just their money but their time. And so I just want to thank the foundations for doing that. So let's give them a round of applause. So for our special invited guests, I want to just do a quick primer of how we got here. Back in 2019, the foundations were saying, so what is going on in South Carolina to address social determinants of health? So we did some interviews, talked to a lot of people, kind of conducted a landscape assessment to really understand what different organizations were doing. We talked to community-based organizations, healthcare systems, safety net partners, payers, state agencies, just to understand what they were doing around addressing social determinants of health, what were the key challenges, and what are the opportunities that we have here in South Carolina. That work led into a design process where we formed a design committee. Many of you were members of that design committee, and were presented the landscape assessment findings as well as a review of a multitude of different action plans like the state health improvement plan, the community health needs assessment plans that were created, the rural health action plans, looking at all those to say, okay, where do we start? Like what target populations and what social conditions? And really what came out of that were two social conditions, housing instability and food insecurity. And then our target populations were mothers with children 0 to 5, adults with chronic disease, and individuals with mental health and substance use disorders. Are anyone surprised? No, right? So as part of that conversation, though, the design committee made it very clear that we cannot talk about infrastructure building around social determinants of health without talking about the issues of structural racism and social isolation. And so we must not only recognize these two issues and their roles and how they affect health, but also we need to come up with solutions that ensure we're not perpetuating these problems. So the design committee also developed the governance structure, which brings us to today, right? So we have 3 cores, our programmatic, our data, and our admin core. And they are really focused on coming to consensus around the infrastructure needs for South Carolina that will enhance the existing efforts that we already have going on in South Carolina so that we're more effectively addressing social determinants of health. And that leads me to say, this work started in 2019, but there's been a lot of work going on in South Carolina already to address social determinants of health. So we are by no means taking any credit for what's already been going on. That's been amazing work. And so when I think about those organizations or initiatives that have been going on in our state, I'm going to just shout some out, but I know there are plenty more. But I think about Live Well Greenville and Live Well Kershaw, Trident United Way, Pals in Spartanburg, Eastern Carolina Housing Authority, the Community Loan Fund, Feeding the Carolinas. I could go on forever, right? And then we have a lot going on at the state level with Food Share South Carolina, SNAP-Ed, SC Thrive, the Center for Community Health Alignment's work, and the Alliance for a Healthier South Carolina, the Rural Health Action Plan, and Access Health, right? So they've been around, they've been doing amazing work. And so we really recognize the significant impact that they have had in our state. This work is really focused on infrastructure building. It is really about enhancing that amazing work that's already been going on in our state. And it really is just one small piece of the puzzle. This work is one small piece. It's not the end all be all. So we have a very packed day today. If you want to show the slide, there is no break this morning. So we're just going to transition. So if you need to go, get up and go, you get up and go. Bathrooms are down the hallway. If you need to take a call, step on out. But don't be gone too long because you're going to miss something important, right? When you first came in, we had some music playing. That is the playlist that you guys, our core members, created. We will make sure it gets out to you. It's songs that we think motivate us or inspire us around this work. And again, I just want to welcome all of you for being here. I hope you leave here inspired and ready to work. Thank you. I am going to pass it over to Renee Lynyard-Gary and Carrie Rothschild, who are going to be even more inspirational and motivating than myself. Come on, Carrie.
Well, that's not intimidating. Yay. I'm Carrie Rothschild. I work in Spartanburg, and I am with the health system there. I spent a lot of years working with Access Health Spartanburg and learned a lot of the information that I'm now so passionate about working with that group, and that is where I met Renee. And so when you reached out to say, Carrie, would you co-chair? I said, and you said Renee is co-chairing, and I was like, okay, sure, because she's been my go-to for so long. I'm now Director of Community Health Policy and Strategy for the health system.
Yeah, and Carrie, I think it's been, wow, probably 10 years so far. More than 10 years, right? So our work started together through Access Health, as Pam mentioned, but I am now the Director of Diversity, Inclusion, and Health Equity at Roper St. Francis Healthcare in the Tri-County area, Charleston, Berkeley, and Dorchester counties. So thank you all for having us today. To begin, I would like to take a moment to recognize the people that are in the room. We are thankful for the team from North Carolina who joined us, but our South Carolina champions in the room, we really want to recognize you. So in alphabetical order, I just want to go through who's in the room by the core, right? Because that's, right? So the admin core, if you would please stand so everyone can see who is a part of the admin core. And you get to meet the co-chairs here shortly. Yes. So that is very important, right? And then even more important is our data core, right? The data-driven strategies of how we move this roadmap. Would the data core team please stand for us so we can see who's in the room? Yeah, those are the people we call out the 10th hour of the day because we need it right now, because we have a meeting tomorrow or there's something going on. So thank you all for being in the room. And then last but not least, our programmatic core team members. Would you please stand? Thank you all for being here today. So on that roadmap, everybody knows I'm the analogy queen. These are the drivers, right? And they come back and let you know, I need maintenance, I need fuel, right? So that's what our programmatic core does. They really are the people moving the work and providing information back to us.
We're going to have as much fun as they are.
I'm about to say. So as I kick off this session here, I want to leave y'all, the music theme is intentional, but as I come into this room and see everybody many times for the first time, right, since we started this work in the winter of 2021, right, it's ain't no stopping us now. So I want y'all to take that with y'all throughout the day, right? So we have to add that to the playlist, Janisha, okay? So ain't no stopping us now. You know, we're on the move, we're ready to go. So what I would like to do is thank you all again for being here. But first, I want to get to the why, right? That's like, so why are we here? First, it's our first opportunity to be in the same room. Boy, North Carolina, that's a bonus one, right? To finally get in front of each other by being here in South Carolina. So thank you. And so we've been meeting virtually, and to finally see people in the room, and if we wave our hands, we give everybody, right? We shake hands with everybody in the room, even if we're not, or rubbing elbows with somebody in the room, and so that's important. Second, we're here to be inspired. I know many times when you're sitting in a room, I think we learned this best through our Access Health Network meetings, is that when you're in the room with individuals, sometimes the different perspectives that you get from sitting at the same table, you can take back to your wheelhouse, and the work explodes sometimes, and you learn new things, but you also get to address the challenges together. And so that's why, the other why of why we're here today. And then last, it's, health equity. I now have health equity in my title. That's a win, right? So you put that at the forefront. If you talk about the evolution and change that has happened over the last 5 years, that a health system recognized how important health equity is in order for us to get the diverse teams, to be inclusive. That includes the extension out to our community. So we're living those missions that we put in front of us along the way. And so that's another why. And then also that health equity lens, that we also make sure that we be intentional and we help drive the work to make sure that everybody steps through the room each day, no matter where we work, no matter what core we're a part of, but we put on our health equity lens all the time. And for many of us, it's been the nature of our work for the last decade or two or more, right? So with that, I want us to take the opportunity to learn so that we can operationalize this plan along the way, and you guys are the key to that, moving the needle and getting momentum behind this work.
And we've learned a lot already, and there's been a lot of research going on, and part of what we've learned, even though we were very much on Zoom and virtually meeting with each other, too, And when the first time we came together as co-chairs, we had little stop sign name badges. So it was like green meant you could touch me or hug me, yellow meant I like you, but stay just a little bit away, and red was like, hands off. So it's really exciting to be in this room now and have so many people that are willing to be touched.
And she's
hugged.
fully dressed in green, so you know you can touch her, right?
I'm a green light, baby. That's right. Some of what we've learned, though, is that this work is very new in the way that we are talking about doing it. And some of the research that's been done in formulating this plan to do this work came across an initiative that was in 2014. And so that was kind of the first date that you found something of this magnitude. But we know that a lot of work has been going on at the local level and all across the country and across the world. And it's time to learn from each other. So we're blazing trails, but we've also got others to learn from. We also know that even though there are examples to learn from, it's not one size fits all, and that each community is different, each state is different, and that we've got to be flexible and willing to adapt to that. And then I think that the most important lesson is that this kind of work really takes courage, and we've got to be willing to be vulnerable, and we've got to be willing to just keep on course. So the other thing is we need to remember why we're here. And so there will be a few videos that we'll have throughout the day to introduce some really important people to you, to talk about the systems and how they are supported. And Janisha will go ahead and start this first video.
So we are all South Carolina natives. We've lived here at least most of our lives. Yeah, we're just a family of three. It's me, my brother, and my mom. I do a lot of data entry kind of stuff, especially in like the medical sort of field, looking into getting actual like medical coding license and all of that kind of stuff. I'm very fond of computers.
I have two kids with special needs, so they're pretty young. So I just stay home because they need me. They're like full-time job already, so I have to be there 24/7. And I'm not working. I wish I could work, but I can't because I have to take care of my children.
I'm originally born and raised from Amarillo, Texas. I've been in South Carolina for the last 6 years. I have two girls. They are both in school, 17 and 13. My 17-year-old will be graduating this year. Just had found out about almost a month ago, well, not quite a month, that she is expecting. And I work currently at Target Distribution Center, working Saturday, Sunday, and Monday, so 36 hours. And I enjoy what I do. I'm just a warehouse worker, but it's room for opportunity out there.
A lot of what we've talked about is the need for community collaboration, for cross-sector, multi-sector participation and relationships. And we've also talked about this centralized system to identify and address social determinants of health and barriers to health. But we've also talked about this culture of positivity, openness, good rapport, and teamwork, and not competing with each other. And so there are three primary challenges we've identified. The first one is silos, And I know we all talk about that all the time, how we're working in silos in our own organizations sometimes even, but that we need to be working together. It's very fragmented right now, and we've talked about the need for a backbone organization to help drive this work. A second thing is poor communication. And so in a time of us doing things virtually, and I might read a text or an email from you and think, why was that so mean? Because you didn't put an emoji. I don't know. But it's very, very easy to misinterpret things, and our communication has not been strong or consistent. And so looking at pooling our resources, communicating together broadly, sharing the same messages with the same language repeatedly, consistently, has been another big thing.
And in that communication, no matter who's at the table, it comes back to sustainability. And many times that means, show me the money, right? So sustainability is one of those things that we have been dealing with in this space for quite some time as a program core. Many times you see large investments from our partners like the Duke Endowment and Blue Cross Blue Shield Foundation. But a lot of times the due diligence on us as directors, VPs, leading these community health programs is to go back and say, how do we braid and blend funding? How can we make up for that? We need more funding for staffing. We need more funding for, sustainability for training and professional development. And that has been the larger part of our communication, about the communication we've had as a core, is around the sustainability of our programming. Because many times, the programs that we lead are what I have termed our kind of incubation, right? Our learning labs about what we can do when we apply address social determinants of health or social drivers of health and what impact that has on outcomes. And so many times that is where it stops sometimes. And so that is a challenge. And I think out of all three, I think that one stands up true to the test of time for me.
We do the report.
We do the
report. And
report.
then it goes on the shelf. We're like, that's a great
Yeah.
plan. Here you go, we did it.
Yeah, and so some of that courage also is to get in front of those individuals who have the influence within our systems and have those conversations and ramping up communication and no longer working in the silo and truly being collaborative. And that means it starts with everyone. Everyone has a shared responsibility in this work. So then there's accelerator projects, right, that will need to be implemented. So we've been on the journey. Some of us have been to the design team meeting, and then we've done the learning collaborative, and now we're doing the core, and now within any, rhythm that we go into, it's time for the implementation. And many times that's through accelerator projects. But I will share this with you, leading an accelerator project around diabetes prevention really help shape in funders or people that have resources about what can be done. And so then that's another opportunity to collaborate. So these accelerator projects that are coming up are going to be so influential in the next phase of this work. And then
Shanisha's going to show
some slides around the challenges, visioning, and assets here. So the programmatic core, our purpose to drive the improvement for priority populations through cross-sector collaborations. Those were some of the key activities and workshops that we had. But when we went through this exercise, man, Carrie, any feedback you have from that session where we just kind of went over what some of those challenges were going through these slides and that long list that we have?
The conversation was great. The trying to use technology to put sticky notes on something was the hard part for me.
Yeah.
But yeah, those three things really stood out: the sustainability, the communication, and the silos. So that's where we're focusing our efforts.
Yeah.
And to get all this done, you called them the most important group, but we have to, because those data people have, a complex. So we want to introduce our data. We have just one of our co-chairs here today. So Melissa Fair will come up and share more about the next from theirs.
Y'all are a tough act to follow. So I'm Melissa Fair, and I'm with Furman University's Institute for the Advancement of Community Health. And my data co-chair, Summer T-Ball, could not be here because of a long-standing prior commitment. So I wanted to recognize her because she's been integral to this work as well. So our vision in the data core is that we would have robust data sharing agreements between all of our partner organizations with high levels of trust and where everyone understands the importance and value of this data. To do that, we see a vision for a case referral management platform that has a centralized repository where data are available at different levels of analysis and units, and that data is secure and accessible to the public or anyone who wants to use it to inform their organizational practice. Going through this work, we did identify that there are some significant concerns, and we were open about that. One of the biggest is security concerns. Data risks in data sharing, cybersecurity. Some of our data also has limits on how we can share it and in what form because of things like HIPAA and FERPA. So we recognize that things have to be in place to protect people's information and or structure the data in a way that it's de-identified. To date, there's no central repository that exists for us to use, so there has to be something created, or something from a partner would have to be built to meet the need. We also identified something we called vision-impaired collaborations. As organizations, we all have different missions and goals and do different types of work. And sometimes these can create differing timelines, competing demands. We're using different systems and platforms that make interoperability difficult. And sometimes there's a lack of transparency about what data is being collected now and or how it can be available. So out of these discussions, we identified a vision and a need for a single case referral management system and platform. This is backed by results from a 2019 nationwide study that talked to more than 300 organizations, including healthcare systems, including federally qualified healthcare systems, rural healthcare centers, and safety net systems like our free clinics, as well as community-based organizations. There were a couple of key themes that came out of this study. The first was that we need a resource directory that's updated frequently and has real local data in it, not just a list of organizations with contact information. We also need a referral. It needs to have outgoing referral capability with a closed loop referral feedback where the information is exchanged between the healthcare provider and the community-based organization. Another key finding from this study was that we have to co-create this. We can't just create it in the silo on the healthcare side and then ask our community-based organizations to uptake and use it. This also means that training isn't just enough. We need to help them create infrastructure and make sure that they have the resources to hire, train, and maintain staff that can use and implement the system. The benefits of this would be, of this single case management system would be reduction in duplication of efforts. We would have reduced gaps in the continuity of care for individuals in the community, and we would have the ability to pull all of our resources to maintain a single system rather than each organization trying to support their own. We recognize that there's challenges though. There's federal rules that are evolving that mean that if we ultimately select a system, we don't know if that system will meet the needs of those guidelines or if it can be changed or upgraded to fit those regulations. We also need organizational buy-in from all of the partners across the state. Another concern is CBO's capacities, especially smaller organizations with really lean staff. This is one more thing for them to do that they could ultimately feel like takes away from their ability to serve their constituents or clients. And the last is that it needs to meet the needs, this platform needs to meet the needs of not just the healthcare providers, but the CBOs as well. And is that all? Okay. So next we have our admin core, and I think Naomi is going to be representing them.
Okay. I'm here as the co-chair of the admin core. We're really excited to be doing this work and just wanted to talk you all through what our conversations have been. So what we really see is a more formalized and robust relationship between the community-based organizations and our healthcare systems, right? Because we're often working with the same people, but in different ways. And so we want to certainly see a more meaningful relationship built there and a more formal partnership. Sustainable funding sources, you'll hear that from everyone, right? That means oftentimes I think we take up work and then the hardest part is the sustainable funding. We say it doesn't work. And the work does, but the funding doesn't. And so what type of work do we need to do to assure that investments follow the things that work? Cross-sector communication and data sharing. You heard that from the data core. We agree from the admin core. Obviously, you'll see some continuity in our messages around the need for case referral management systems, because that really is about the individuals involved and how they move from place to place and how challenging that can be. And a dashboard that shows positive health outcomes, right? The ability to see what's going on in the community level and be able to communicate that. Based on a diversified set of data. And trust building is important, right? That we trust each other, that the systems themselves, that we're all working together. And that racial equity needs to be a part of that, right? We understand if we move to a system, are we, whatever system we're using, is it inclusive of everyone in every community, and that needs to be at the forefront of the work that we're doing. So, it's find what works and do more of that, right? Like, that's always a model that we try to use. So we looked at other states and how they funded their social determinants of health efforts and examined sustainability strategies. So you can see here, how do we use Medicaid dollars for food insecurity and housing? We know those are two major areas that impact health outcomes. And then testing the value-based payment models. And learning through the Healthcare Payment Learning and Action Network Alternative Payment Model Framework. That's a lot. So with 3 phases, so you'll see here on the screen all 3 of the phases and how we work through. So hopefully everybody has their reading glasses on and can see that far. But there's the short-term, low-risk fund for pilot and demonstration projects and small-scale federal grants. So, we're looking at what has worked in other places to assure sustainability. So as all of you put your time, energy, efforts, collaboration into this, we want to make sure that we leave a long-term legacy, not a short-term project. And in order to do that, we move on to phase 2 and phase 3. Which is program expansion after demonstrating promising results, right? Asking ourselves important questions as we go, like, is it working? And then dedicated state pools or trust funds and Medicaid waivers. And that takes all of us and all of our voices added to the conversation to make that happen. And then phase 3 is the dream, right? Is the fully operational programs that are demonstrating positive outcomes and cost savings supported by combined sources. So, and then looking at blended and braided local, state, and federal financing. So those are the key strategies for what we are looking for and why we hope you all continue to show up to the table. That this is a marathon, not a sprint, and that It will take longer term dedication, but there is a path, and we'll continue to learn from that. And so that is, from the admin course perspective, what we see as the key components of really bringing it all together. So I think that's it from the admin core. And I am going to pass over to my lovely counterpart, Greg Parable.
Everybody, I'm Greg Maribel, pediatrician, and I pivoted from being chief medical officer, one of the Medicaid managed care organizations in South Carolina, to work more directly with community and community organizations. Very proud to say I'm the physician advisor for the South Carolina Office of Rural Health, and I get to work with Pam Gill and her team, Julie Smith and her team, and really to bridge the gap between what's happening in the community, what the payers do and know, and how they work with Medicaid. So for this project, we asked that that we could engage with the MCOs and he said yes! So we have five managed organizations in South Carolina. The two with the stars are organizations that also have sister plans in North Carolina, so we're very interested to talk with them about their experience. So Absolute Total Care, First Choice by Select Health, Healthy Blue, Humana Healthy Horizons, which just came into the state July of 2021, and Molina Healthcare. Anyway, I got really silly with transitions also. I was having a lot of fun. So we did an initial survey to kind of guide what is going to be our qualitative interviews with the managed care organizations to talk about the different components of what they think they need to be able to participate in a meaningful collaborative. They didn't put it on there, but obviously it's money. I mean that's. But and I think from what we heard from the survey is a lot like what's coming from the courts. Everyone is aligned in the same way to want to move the needle forward, or move everything forward from social determinants of health. But it's what are the drivers that can happen? So right now what they're doing. So they are in some ways collecting information about social determinants of health. They're using multi-channel sourcing, meaning they're doing the web, smartphone, the please press 3. Our options have changed. But across the board, I think because it's DHHS sponsored, they're all integrating the findhelp.org, used to be Aunt Bertha, as ways to connect to the community resources. They're using standard screeners like the Prepare, but also all of them have their own proprietary customized screeners, and a lot of those are built into their case management, sometimes their utilization management platforms. They're using claims-based, so ICD-10 codes, the Z codes that indicate that there is a social determinant of health issue. The two problems that I see with the Z codes are, one, is that for pediatrics, it leaves out that a child can be affected by a social determinant of a parent. And so we haven't gotten to the place where you could say, because of a caregiver's social determinant issue. The other thing is with the Z codes is that while I could say there's a presence, there's nothing to say that there's the absence of it, right? That's been addressed, and so it's not really a great way to be able to track longitudinally social determinants of health and the correction of it. And they all have proprietary population health software that's now integrated with social determinants of health with their medical and pharmacy data. And these platforms, I call them artificial intelligence. Because they have these predictive models of here's how much this person's going to cost next year. Here's the probability they're going to go to the ED or the hospital. But what I see in that is a way to peg the cost savings that happen in a system to interventions that are going on. But in doing that, you really have to think about, interventions are multi-layered. And so even if we're addressing something in terms of food insecurity for a diabetic, I think of like a 100-point scale where there's still, the physician, there's the diabetes educator. So we have to kind of think holistically also about where we attribute cost savings and improvements in health. So the social determinants and issues, and it just kind of came to me as I was sitting here looking over my slides that if you go to SouthCarolinaHealthyConnections.com and it's find a health plan, and you look at the different managed care organizations on the bottom, it has their value adds. And these are things that are paying outside of the Medicaid dollars, but they really are, if you look through, a lot of them are going towards like GED programs, bike programs, a lot of stuff around nutrition, some post-COVID, some for pregnancy, and affordable housing. And so, they're already doing these things. And so I think there is a way to take what we're doing right now and be able to start integrating in to get some cohesiveness around where they're putting the money, how they're investing it, and because a lot of these are local, to kind of bring them more statewide. And we asked them, so they said they're working with you guys, right? Like in some sense, they are working with organizations, but there's not cohesiveness around, who they're working with. And so I think it'll be interesting to kind of come back out to you guys as our community partners and say, which managed care organizations are you directly working with? And then to be able to, kind of socialize the information for the ones that you are. So, and kind of the core of it, I think what was year one of the North Carolina 1115 waiver was the infrastructure needs. What needs to change? What do they need supporting from an administrative perspective? Again, what are they expecting the state Medicaid authority to provide for them to be able to do these components? So, and again, a lot of them are very, very similar to what's coming out of our codes. So the standardized information exchange, both a health information exchange and a community information exchange. And I think, in my mind, they have to be thought of separately. Not that they're not integrated, but they serve different functions, different purposes, and also they have different security risks, right? And so, kind of separating out what they're doing, but then bringing it back together for what they can accomplish, I think is something that's important. Data Support Health Equity Certification. So there's the National Committee on Quality Assurance that now has something called a Health Equity Certification. And it brings in multicultural healthcare distinction components and then social determinants of health. And a lot of these, in the beginning, it's data sharing, it's making sure they have the systems, aligned to be able to collect that information. But this is something that I think is a value driver for them because they have to do it. And so we're looking into how do we integrate in what we're doing. So the transportation systems, central data sharing, the mechanisms to support community-based organizations, which again I think is something that North Carolina did beautifully, and that we need to look at here, and then the consistent funding. Thank you.